We usually get rid of the seizures in about 90% of the patients.
How many people with epilepsy have you worked with, Dr. Walker?
I've had about 150 patients. So in addition to being able to reduce and often eliminate seizures, we can help them with the cognitive problems that they have. You know, it's very, very profitable for the neuroepilepsy surgeon and for the people who monitor the epileptics. They can get paid fairly well to do that, but so they haven't, as a group, been impressed, mostly because they haven't been aware of the fact that neurofeedback can cure epilepsy.
How often do you get a phone call from a neurologist, epileptologist asking about your approach?
Maybe once every few years. Well, I welcome the opportunity to be able to interact with students at an early phase in their career when they're still open-minded. I'm a neurologist, and I've had a particular interest in epilepsy for 30 years. I used to do epilepsy monitoring and work with surgeons to remove seizure foci. I came upon a different approach, which I think is a better approach and a more effective approach than neurosurgery, and that is QEEG-guided neurofeedback. So quantitative EEG is using a computer to compare a person's brain waves with a normal database. And when you do this in an epileptic patient, what you find is a lot of focal slow abnormalities, which don't show up very well with routine or raw EEG. It's a more sensitive test. The slow abnormalities often correlate with cognitive difficulties that epileptic patients have. So, for example, many of them have ADD, which is associated with slowing in the frontal areas. And fairly commonly they have difficulty remembering, which correlates with slow activity in the temporal lobes. So in addition to being able to reduce and often eliminate seizures, we can help them with the cognitive problems that they have. Recently, we've also been able to help the depression that's very common in epileptic patients with a technique which is not based on the brain map, but just an empirical technique to train what we think is probably the amygdala by putting an electrode over the right frontopolar region and training down slow activity and training up fast activity. Thus far, in every instance where we've been able to normalize the EEG, we've been able to eliminate the seizures. We usually get rid of the seizures in about 90% of the patients. Most of the people that I've trained have what we call medication-resistant epilepsy. That is, they've tried 3 or more medications and have not been successful in controlling their seizures. And that's the basic criterion for epilepsy surgery. And in that population, our results are really better than with epileptic surgery, temporal lobe or frontal lobe surgery. We have about a 90% success rate, and their success rate varies from center to center, but it's probably 60-70%. There also are complications from the surgery, such as if you remove the hippocampus, you get memory loss. And there are the occasional patients who develop new seizures after the surgery, which makes sense based on our understanding of what causes seizures, or what the abnormal brain activity is that causes seizures. So yes, it's true that you can eliminate the seizures by cutting out the focus, but you're probably cutting out a normal part of the brain, and you're ignoring where the biochemical lesion is, which is where the slow foci are.
How many people with epilepsy have you worked with, Dr. Walker?
I've had about 150 patients.
You gave a presentation at the AES, and if you want to just describe the number of people that attended and maybe the questions that followed.
We had a mini symposium at the American Epilepsy Society with Dr. Barry Sturman, who was the first person who did neurofeedback for epilepsy. We had about 30 people who came, 30 neurologists mostly, epileptologists who came to the meeting, and a couple of them have started doing this work, one at the University of Colorado and one at the University of South Carolina. I'm sad to say that most epileptologists are hooked into the idea that the seizure is in the focus, and that, you know, it's very, very profitable for the neuroepilepsy surgeon and for the people who monitor the epileptics. They can get paid fairly well to do that, but so they haven't, as a group, been impressed, mostly because they haven't been aware of the fact that neurofeedback can cure epilepsy.
How often do you get a phone call from a neurologist, epileptologist asking about your approach?
Maybe once every few years.
What would you say is the average number of training sessions needed to get a satisfactory response?
Well, about 60 sessions is typical, but
And
it can be 20 or it can be 100.
if I learn that I have epilepsy, and instead of maybe starting a medication even, or just when I first start the medication, if I started your program, I probably wouldn't need the 60 sessions of training.
I think that's probable, although I haven't.
No way to tell.
All
right. Had to ask.
Split up
Well,
my
okay,
patients in that way.
Do you have any last words for these medical students, Dr. Walker? If you were starting
Well,
over, what would you...
I would hope you would become aware of the potent effects of neurofeedback for a variety of problems. It's not just for epilepsy, although that's one of the better uses of it. In the last year, we've come up with a way to prevent enuresis, for example, and depression, which is a big problem in our society, not just in epileptics. But it's a burgeoning field, and there are many applications which, by the time they become able to do it, almost every patient that walks in the door of my office would benefit from neurofeedback, including people with closed head injuries, PTSD and blast injuries, like in our military, which is an epidemic, and ADD, which is about 20% of the population has. It's a way of curing ADD as opposed to suppressing the symptoms and not have the side effects of the drugs.
Good. Okay, well, unless you can think of something else you might want to say, Dr. Walker, thanks a lot.
Thank you.